The brain is a complex organ at the center of our nervous system. Multiple regions of the brain are involved in the regulation of emotions, including reward and pleasure. One such region that regulates the reward pathway is the ventral tegmental area, or VTA. The VTA is stimulated by different activities, including eating, exercise, and sex. Activation of the VTA induces the release of dopamine into the nucleus accumbens. Dopamine promotes the feeling of pleasure and euphoria. One of the major neurotransmitter systems involved in modulating the dopamine reward pathway is the endogenous opioid system. The ventral tegmental area is an important part of this pathway. Within the VTA, mu-opioid receptors found on the surface of neurons are stimulated by endogenous opioids, such as beta-endorphin. Beta-endorphin binds to and activates mu-opioid receptors. This interaction induces a signal which travels along the axon, ultimately resulting in the activation of dopaminergic neurons. Here, at the dopaminergic neuron, the signal stimulates the fusion of dopamine-containing vesicles with the presynaptic membrane. This event releases dopamine into the synapse. Once released, the dopamine molecules traverse the synaptic cleft, binding to dopamine receptors found on the postsynaptic membrane. In doing so, they activate a series of neurological processes that create feelings of reward, pleasure, and euphoria. Repeated exposure of pleasure and euphoria or reward result in a learning process called reinforcement. Memories are formed that connect these episodes with their causes, which are known as conditioned associations. Like endogenous endorphins, opioid drugs such as heroin and opioid analgesics bind to the mu-opioid receptors in the ventral tegmental area. Opioid drugs, when misused, stimulate excessive release of dopamine relative to endogenous opioids, producing feelings of intense pleasure or euphoria and further drug wanting. Over time, repeated exposure to escalating doses of a full opioid agonist produces tolerance, meaning that higher and higher doses of the full agonist are required to achieve the same effect. As tolerance develops, higher quantities of opioids are required to produce the same effect previously experienced during initial opioid use. Tolerance and physical dependence makes the addicted patient susceptible to withdrawal symptoms. At this point, the patient is using opioid drugs daily to avoid the unpleasant symptoms of drug withdrawal. Partial opioid agonists are substances that also bind to mu-opioid receptors. Partial agonists stimulate the mu-opioid receptor and produce a less powerful effect than a full agonist. Because partial agonists still activate mu-opioid receptors and promote the release of dopamine, they can lead to dependence and subsequent withdrawal if discontinued. Physiological dependence on opioids results in the need to continue full or partial opioid agonists to avoid withdrawal symptoms. As opioid use continues, the brain changes over time, increasing its activation with stimulatory neurotransmitters such as norepinephrine, producing symptoms of physical dependence. Many of these changes occur within the limbic system in the brain. Next, we will turn our attention to the phenomenon of opioid withdrawal, which is a consequence of those changes. The locus coeruleus is a region of the brain involved in arousal and alarm. Many neurons in the locus coeruleus region of the brain produce norepinephrine. Norepinephrine regulates a variety of central nervous system functions, including the regulation of respiration, blood pressure, and general alertness. Imbalances in this neurotransmitter contribute to the symptoms of withdrawal when opioids are discontinued. Opioid use stimulates mu-opioid receptors, which in turn inhibit the release of norepinephrine in the locus coeruleus. To offset this inhibition, neurons within the locus coeruleus increase their activity, releasing additional norepinephrine. Upon discontinuing opioid use, stimulants such as norepinephrine are now unopposed by opioids. An excessive amount of norepinephrine in specific brain locations produces symptoms of withdrawal, including muscle cramps, anxiety, and diarrhea. Please see important safety information throughout and at the end of this video. Also, please see Vivitrol prescribing information and medication guide. Vivitrol, naltrexone for extended-release injectable suspension, is indicated for the prevention of relapse to opioid dependence following opioid detoxification. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Vivitrol is contraindicated in patients receiving opioid analgesics, patients with current physiologic opioid dependence, patients in acute opioid withdrawal, and patients who have failed the naloxone challenge test or have a positive urine screen for opioids. Vivitrol is also contraindicated in patients who have exhibited hypersensitivity to naltrexone, polylactide coglycolide, PLG, carboxymethylcellulose, or any other components of the diluent. Vivitrol with microsphere technology delivers naltrexone continuously over the approved 1-month dosing interval. Naltrexone, the active ingredient in Vivitrol, is embedded on and throughout these microspheres. The microspheres are biodegradable polymers composed of polylactide coglycolide, a complex sugar designed to gradually release naltrexone in therapeutic concentrations over a 1-month period. After administration, water absorption causes the Vivitrol microspheres to swell and slowly release small amounts of naltrexone at or near their surface. Vivitrol injections may be followed by pain, tenderness, bruising, or pruritus. However, in some cases, injection site reactions may be very severe and may require surgical intervention. Over time, the polymers degrade and break down, releasing more naltrexone over the 1-month period. The polylactide coglycolide polymer breaks down to its monomer, which is then metabolized by the body and eliminated as carbon dioxide and water. When reversal of Vivitrol blockade is required for pain management in an emergency situation in patients receiving Vivitrol, suggestions for pain management include regional analgesia or use of non-opioid analgesics. In addition, cases of hepatitis and clinically significant liver dysfunction were observed in association with Vivitrol treatment. Discontinue use of Vivitrol in the event of symptoms or signs of hepatitis. Naltrexone binds competitively with highest affinity to mu-opioid receptors. By tightly binding with these receptors, naltrexone, the active ingredient in Vivitrol, produces an opioid agonist blockade for 1 month. While reversible, the blockade prevents the subjective effects of opioid drugs such as euphoria. This blockade, in combination with psychosocial therapy, is thought to contribute to the prevention of relapse to opioid dependence. Because Vivitrol blocks the effects of exogenous opioids for approximately 28 days after administration, patients are likely to have a reduced tolerance to opioids after opioid detoxification. As the blockade dissipates, use of previously tolerated doses of opioids could result in potentially life-threatening opioid intoxication. Any attempt by a patient to overcome the blockade produced by Vivitrol by taking opioids is very dangerous and may lead to fatal overdose. Patients should be told of the serious consequences of trying to overcome the opioid blockade. Vivitrol is a mu-opioid receptor antagonist, which, unlike full or partial mu-opioid agonists, does not stimulate brain processes that create feelings of pleasure and euphoria. Vivitrol is not addictive and does not lead to physical dependence. Because Vivitrol competes effectively at mu-opioid receptors and is an opioid antagonist, it will precipitate withdrawal in opioid-using patients. Therefore, patients must be opioid-free for a minimum of 7 to 10 days before starting Vivitrol treatment to avoid precipitation of withdrawal that may be severe enough to require hospitalization. You should also monitor patients for the development of depression or suicidal thinking. Opioid dependence is a devastating disease that currently impacts 1.3 million Americans. Vivitrol is the first and only once-monthly, non-addictive, non-narcotic medication approved to prevent relapse to opioid dependence following opioid detoxification. Important safety information for Vivitrol. Naltrexone for extended release injectable suspension, 380 mg per vial. Indications. Vivitrol is indicated for treatment of alcohol dependence in patients who are able to abstain from alcohol in an outpatient setting. Patients should not be actively drinking at the time of initial Vivitrol administration. Prevention of relapse to opioid dependence following opioid detoxification. Vivitrol should be part of a comprehensive management program that includes psychosocial support. Contraindications. Vivitrol is contraindicated in patients receiving opioid analgesics with current physiologic opioid dependence, in acute opioid withdrawal, who have failed the naloxone challenge test or have a positive urine screen for opioids, who have exhibited hypersensitivity to naltrexone, polylactide coglycolide, PLG, carboxymethylcellulose, or any other components of the diluent. Warnings and precautions. Vulnerability to opioid overdose. Because Vivitrol blocks the effects of exogenous opioids for approximately 28 days after administration, patients are likely to have a reduced tolerance to opioids after opioid detoxification. As the blockade dissipates, use of previously tolerated doses of opioids could result in potentially life-threatening opioid intoxication, respiratory compromise or arrest, circulatory collapse, etc. Cases of opioid overdose with fatal outcomes have been reported in patients who used opioids at the end of a dosing interval, after missing a scheduled dose, or after discontinuing treatment. Patients and caregivers should be told of this increased sensitivity to opioids and the risk of overdose. Any attempt by a patient to overcome the Vivitrol blockade by taking opioids may lead to fatal overdose. Patients should be told of the serious consequences of trying to overcome the opioid blockade. Injection site reactions. Vivitrol injections may be followed by pain, tenderness, induration, swelling, erythema, bruising, or pruritus. However, in some cases, injection site reactions may be very severe. Injection site reactions not improving may require prompt medical attention, including in some cases surgical intervention. Inadvertent subcutaneous adipose layer injection of Vivitrol may increase the likelihood of severe injection site reactions. Select proper needle size for patient body habitus and use only the needles provided in the carton. Patients should be informed that any concerning injection site reactions should be brought to the attention of their healthcare provider. Precipitation of opioid withdrawal. Withdrawal precipitated by administration of Vivitrol may be severe. Some cases of withdrawal symptoms have been severe enough to require hospitalization and management in the ICU. To prevent precipitated withdrawal, patients, including those being treated for alcohol dependence, should be opioid-free, including tramadol, for a minimum of 7 to 10 days before starting Vivitrol. Patients transitioning from buprenorphine or methadone may be vulnerable to precipitated withdrawal for as long as 2 weeks. Patients should be made aware of the risk associated with precipitated withdrawal and be encouraged to give an accurate account of last opioid use. Hepatotoxicity. Cases of hepatitis and clinically significant liver dysfunction have been observed in association with Vivitrol. Warn patients of the risk of hepatic injury, advise them to seek help if experiencing symptoms of acute hepatitis. Discontinue use of Vivitrol in patients who exhibit acute hepatitis symptoms. Depression and suicidality. Alcohol and opioid-dependent patients taking Vivitrol should be monitored for depression or suicidal thoughts. Alert families and caregivers to monitor and report the emergence of symptoms of depression or suicidality. When reversal of Vivitrol blockade is required for pain management. For Vivitrol patients in emergency situations, suggestions for pain management include regional analgesia or use of non-opioid analgesics. If opioid therapy is required to reverse the Vivitrol blockade, patients should be closely monitored by trained personnel in a setting staffed and equipped for CPR. Eosinophilic pneumonia. Cases of eosinophilic pneumonia requiring hospitalization have been reported. Warn patients of the risk of eosinophilic pneumonia and to seek medical attention if they develop symptoms of pneumonia. Hypersensitivity reactions. Patients should be warned of the risk of hypersensitivity reactions, including anaphylaxis. Intramuscular injections. As with any intramuscular injection, Vivitrol should be administered with caution to patients with thrombocytopenia or any coagulation disorder. Adverse reactions. Serious adverse reactions that may be associated with Vivitrol therapy in clinical use include severe injection site reactions, eosinophilic pneumonia, serious allergic reactions, unintended precipitation of opioid withdrawal, accidental opioid overdose, and depression and suicidality. The adverse events seen most frequently in association with Vivitrol therapy for alcohol dependence include nausea, vomiting, injection site reactions, including induration, pruritus, nodules and swelling, muscle cramps, dizziness or syncope, somnolence or sedation, anorexia, decreased appetite or other appetite disorders. The adverse events seen most frequently in association with Vivitrol in opioid-dependent patients also include hepatic enzyme abnormalities, injection site pain, nasopharyngitis, insomnia and toothache.